I'm going to piggyback a little bit off of last hour and how to connect with patients and talk about some things related to patient satisfaction. If you work in a hospital system, this may be a little more familiar to you than if you work in a standalone lab or if you've worked in a physician's practice for years. But regardless of where you work, chances are you've put some of these principles and practices into your daily work life or your night life if you're a night technician. And so what I want to try to do is explain why it matters, and then in the second half of the presentation, which will probably terminate before we hit the time for break. So I'll make up for 8 or 10 minutes that we lost changing out. And to do that, I want to cover what service excellence looks like, what it is, who does it, and this acronym that you may have heard kicked around for many years now called ADET, and explain what can help you in terms of scripting, key words at key times to use with handling patients so that they feel like they've got your full attention and that they have got your care in their keeping. So as you start your night, for example, you're in a race against time to get the demographics into the computer, to get the patient into the room, to sign the releases and the consents, to get them hooked up, get them to bed, because nobody told you that they go to bed at 9:30, but their H&P says 11. And so you've got all these things that you're trying to do, but if you can establish some basic and recurrent, regular terminology and handling with folks, with key words at key times, they're going to feel like you've got that connection to them a little sooner. Now, will it keep them from telling you their whole life story during the hookup? Probably not. But we also want to talk about a way to follow up with your patients. And some patients, or rather some people in hospitals, have been doing this for many years, and that's discharge phone calls. As we'll see toward the end of the presentation, discharge phone calls are going to conjure up a lot of leftovers, a lot of to-dos, but they serve to clarify next steps with patients so that they know who they should hear from next. And that's one of the biggest in my career that dates back to not quite as far as one other in this room, but to 1990, is that patients don't know where they stand in the process. They don't know where they are on the shuffle. Even if they have come to a medical center or a hospital that's got completely hardwired doctor and technician ambiotic relationship, and that everybody seems to be a very close-knit team, they still get lost in the shuffle if they're a direct referral. They still don't quite understand where they're going next, oftentimes because they've got so much going on. A lot of them have comorbid conditions, a lot of them are going for appointments with other family members and so forth, and so I say all this to say there's a lot of distraction. And so when these discharge phone calls go out to them the next day or hopefully the day of, saying, oh, Mr. Smith, by the way, my name's Robert, I was just calling to see how we treated you last night, and kind of let them ramble for a few minutes and give them some open-ended feedback, and then to tell you, oh, well, I don't know where my next appointment is. Okay, well, anything that you get, you work with, and you let them know or have somebody let them know for you. The last two things on the hour are going to be focused on how to handle, bad service that sometimes is out of your hands. I remember in the first couple years of being a manager in the early 90s, I spent probably a third of my day apologizing for things that weren't my fault or that were out of my hands, because I had sleep but also had neurophysiology, and at that point I didn't have a whole lot of experience in EEG or neurophys, and I had a group of neurologists next door that made my life real interesting. So apologizing to a patient is something that if you're on day shift or you're a coordinator or a manager, that you're going to have to get comfortable with at some point. Okay, so how do we do this all, and why does it matter? The person that really drove this from the early 1990s was a guy named Quint Studer that decided that he had to find some way to up the scores of the hospital, the patient satisfaction scores, from 25% to something much better. Now, the scores that he was working with at the time, I believe, were what we in the hospital systems know as Press-Ganey scores. And Press-Ganey scores have to do with, in a small part, how hospitals get reimbursed. So this is part of why patient satisfaction is so important, not just because we want our patients happy and knowing where they're going next and that we've connected with them, but they have to know that there are people in the process that are going to reach back out to them. And what Quint was deputized to do is take this hospital where he worked at from a very low score to a very high score. And when he did that, he became a very hot commodity. He was recruited by another hospital, made CEO, and then when he went to Pensacola, he did the same thing. And so what his secret sauce was a combination of scripting and behaviors that empowered everybody on the team and made them nearly equal. Okay, and safety in hospitals now is built around that philosophy that everybody, should have an equal say when they are considering a patient's welfare and safety and things that stand in the way of that. So anyway, his end result at Baptist was that he raised these patient satisfaction scores to 99% by using this simple ADET acronym. Okay, there's his book, and this is largely the reference for my presentation from 2003 called Hardwiring Excellence. If you've been in, not just sleep, but in healthcare for any amount of time as a coordinator, manager, or director, or leader, there's a good chance that somebody somewhere has had you or asked you to read this and to wrap your head around ADET and around the pillars of excellence. So what I didn't say was I have no financial disclosures. Okay, I'm not on the payroll for Studer. Okay, so you make that clear. So what our customers want from us, okay? They want our respect, they want our courtesy, they want us to treat them well, and they want us to give them some relief from their problem. A lot of them that come to us, though, present a special challenge because many of them don't think they have a problem. Have you ever had a guy, especially male patients, will come in and say, I don't have any problem, I sleep just fine, okay? It's my wife that's got the problem, or vice versa. Now, in many labs, I think we see about as many female patients as we do male, but largely male patients, need all the same things that female patients need. They're just not as likely to tell you. Okay, so what service excellence is? It's more of a behavioral approach and set of habits that's practiced over and over and over again to make sure that the same patients from day to day, from month to month, from year to year are getting the same treatment and the same handling by your team as the ones prior to them or the ones coming ahead of them or coming in the future. This all works together to build a positive culture so that you have folks that feel when they leave your care, they feel like they've had service that goes above and beyond every time. Now, lots of challenges around that. The first of which I mentioned earlier is that your physical timeline in getting the patient in through the door, signed consents, hooked up, into bed. That's a lot to ask when a patient comes in, ticked off that they've gotten bad directions or they've lost their way and they come up the wrong elevator, go to the wrong medical office building. So, you spend, in many nights, a good amount of time de-escalating the patient and making sure that you can build a rapport with them. So, some tools coming along here in the next couple of slides will help you do that and help you focus on what that ADET acronym can do for you in situations like that and how to present yourself in the lab. Okay, so here's what it stands for. Again, many of you may have already seen this and learned it over the years, and I'm going to give you examples of how this can be put into practice in a sleep lab, not on a nursing floor, not in an ER, not in radiology department, but in a sleep lab. So acknowledge, introduce, duration. Duration and explanation often go hand in hand together in the same breath, literally, when you're explaining what's going to happen for the night. And this is particularly important, I felt in my career, in setting the stage when somebody comes in to be tested, that they understand that they're there for a medical procedure. They're not there to bring in their bag of McDonald's and have a picnic on the bed and all that. Everybody's had that. And it's hard to get them started. But if you bring them in, sit them down, explain to them who you are, why you're here. And I used to encourage my techs to say, you're not here for a sleep study. You're here for a polysomnogram. And let me tell you what that is. Because then they've got a medical term that they may not understand, but it refocuses them to the fact that they're there for a medical test, not just to lay in the bed all night. Okay? And oftentimes that's part of your greatest challenge in the people and the patients that don't want to be there. Okay, so acknowledge. Here's a feasible example of a patient coming in. This is Mr. Hollings. He's our 79-year-old patient who has driven round and round in the rain and had a 1-hour commute to the sleep lab. And as he parks, makes his way to the medical office building, finds the elevator to the sleep lab. On the way to the door, he drops his questionnaire. So he's good and ticked off by the time he reaches your door. And once off the elevator, he finds the lab, and you come to the door and greet him. But before you do, you're in the control room with several other techs, or at least one other tech, hopefully, and you're getting yourself ready for the night. Could be that you're in another room with a patient and you don't hear the doorbell. And this, again, is one of the things that can get your night off to a bad start. But anyway, as you acknowledge the patient that is coming in, it's not their responsibility to acknowledge you. So you've got to tuck all that away if you've got any beginning of the night frustration, or if you've got things to deal with that you didn't expect. As he comes in, you might say, Mr. Hollings, you've had quite a night already. Let's get you settled and explain to you why you're here. Is there anything I can do to make you more comfortable right now? And then, after you do that, you're going to roll into the I of ADAT. You're going to introduce yourself. And you may say, hey, I didn't really like this after I found it, but I was told over the years I need more pictures. This guy looks like he's in a circus. My name is Rodney. I'm a registered sleep tech. I've been here with Townsend Memorial for 6 years. Okay, manage yourself up a little bit. Sometimes ladies, women, in just a fact, have a little bit harder time managing themselves up. But if you've been a sleep tech for 18 years, registered or not, you're going to take really good care of that patient. They need to understand that you just didn't walk in, from Hardee's the day before. Okay, it's real important. Consider your tone. Tell them that we're going to take very good care of you tonight. Smile. Consider your body language. Consider your tone, especially if you've had a rough start before the patient gets there. Make eye contact. And this last little bond comment here, you can be shaken but not stirred. You can be shaken and already a little bit anxious about your night. But in front of that patient, as long as you're with them on the way to the room or in the room or talking to them over the intercom, they're your focus. And you need to understand, especially men in healthcare, they've got a deeper, larger sounding voice with female patients or with male patients that just they're more sensitive and felt like they've been kicked around the health system. Everywhere they go, they're being fussed at or they're being yelled at. You just really have to consider, how you're coming across when you're asking somebody to do something. Had a patient, or rather a technician, not 5 years ago that was recorded fussing at a patient over the intercom to, Mr. Smith, we need you to sleep on your back. Every time that they reminded him of that to try to get supine sleep for the doctor, they ratcheted up the tone just a little bit more. So you can imagine, by the end of that night, patient sleep efficiency was poor, and the patient was very dissatisfied with the service. So regardless of a technician's technical aptitude, the patients who come to us assume that we have technical aptitude, that we're checked off, that we're trained, that we're competent. It's the soft skills that make a difference. And the reason that's, in my mind, so important right now is there's a shortage of techs. I look around the room at all the white and the gray in this room. BRPT, AST survey a couple years ago showed that, I don't remember, 60 or 70%, 70%, something like that, of the registered techs are all over the age of 50. So as the field narrows and competes for staff and competes for people, there are going to be fewer and fewer centers, and certainly with the advent of home testing. So people with insurance or without insurance, they have a choice. So you would like to have your folks leave with, gee, well, you know, I can't wear that CPAP, but God, they were nice to me. You know, I got a cup of coffee on the way out. Lady walked to me, or security, the lady who's my tech had security walk me to my door because I get up early, but I didn't want to go out to my car in the dark. There's extra things just like that are what patients remember. So again, a lot of nights we're going to be anxious, we're going to be shaken, we're going to be in a hurry, but we can't let that show to the patients. You know, while we're with them, just treat them like you'd want to be treated. It's kind of the old adage, it's a very cliche adage, but it's true. So when you go into the explanation or duration and explanation of what all the patient's here for, an example may be that, hey, Dr. Fessmeyer has ordered this sleep study for you so that, you know, we can diagnose you. You'll be here all night. The purpose of the study is to see what you do while you're sleeping. Keep things simple, not a whole lot of deep terminology. We want to see if your breathing is regular, if you kick and move your legs, do you have any unusual body movements, and what your oxygen levels are. And those are the highlights for most tests, okay, unless you're being, you know, carried over the next day for an MSLT. For the next few minutes, okay, duration, I'll be reviewing some registration forms with you, consent to treat forms, patients' rights and privacy act, and so forth. And then after your study begins, we'll be monitoring you so that, you know, we can watch your sleep and watch, you know, what all you do, but then respond to you through the intercom. If you need anything during the night, just call out for the bathroom and we'll unhook the main cable from the jack box and we'll help you up. In this duration and explanation segment, you've covered about 70 to 80% of all the questions a patient's going to have about how their night's going to go if they've never been to a sleep lab. And you can fit all this in really quickly. The chitter chatter and the family history that they'll give you while you're hooking them up, okay, well, you're still getting things done that you need to get done. But when you do this in this manner, you not only relieve a little or much of their anxiety, but you get covered and you set the stage for how the rest of the night's going to go. Okay, they're here for a medical test. You're going to be here all night, and you're going to be not restrained, but you're going to be kind of strapped to the bed so that you'll have to ask for help to get up. You know, so many of our patients now are fall risks, so it's really important that they not try to get out of the bed. And then, thank you. Why would we tell a patient thank you for coming to our facility? Or thank you for choosing. Quint Studer's original rules and approach to things was that you thank them for coming, rather for choosing your hospital or your sleep lab. Well, times that I've used that as a night tech myself, you know, I was corrected by many, many a patient saying, well, this is where my insurance told me I had to come. So that's why, thank you for, you know, coming here, not for choosing here. And that may save you a little embarrassment, especially if somebody's just not really wanting to be there. If you use ADET or something like ADET in all situations, it's going to cover so much for you. And it's going to, again, throughout a group, whether it's a 4-bed lab or a 20-bed lab, and there's very few of those anymore, obviously. But when you're working with people, y'all know that not everyone has the same work ethic, okay? But if you're all speaking the same language, then, you know, you're one step closer to, you know, betterment of teamwork. And for the folks that, you know, don't play ball and you're not giving them a little peer pressure, then, you know, you're accepting that. I'll talk about that in another slide. But we also, by doing all this, enhance the patient's perception of their care. We help provide a lot of good transitions from, you know, getting them in there, getting them in the chair, getting them, to be hooked up, getting them prepared for bed and so forth. And you really just set yourself up for a smoother night. And everybody who's worked longer than a year or two has got their own way of doing this and probably do every bit of it. But for the folks that have never worked in a hospital system or a more structured environment than possibly a physician-owned lab, a lot of this, can really help. It can help create a sense of autonomy and security for the patient so that they know that they're there and being cared for by somebody who wants to be there. And especially now, if your friends or your work friends don't want to be there, then you can make it your business to help them, return to the community possibly, because they're not doing you any favors. The physician, yourself, and your team is being represented by them. And so when you get a patient, and many of you probably have gotten this, where another tech has had them, and they come in, and all they do is talk about the first tech. It doesn't happen too often, but when it does, it's very telling. Okay, so some examples of keywords. Mr. Hollins, I'm going to close your door for your privacy. And at this point, you can use the I in ADET for introducing a coworker or a caregiver that's going to be working on them also. Do you need anything else? I have time. Or if you're busy with another patient and you're in a control room, you hear them call out to go to the bathroom in the middle of the night. You just want to reassure them that there's going to be a next step, and that you use some kind of standard reply so that they know that you're going to be handed off, or you're going to be the one coming back to them. Okay. Some other examples. Some of them are more applicable to nursing and more applicable to outpatient services, which we are. But the one that goes hand in hand with our discharge phone calls that we're going to get to in a few minutes is, here's what I can do to get you what you need. Okay, because people will take you down a path like the presenter last hour was discussing and describing. I hate the DME. I hate, they launch into their tirade or their explanation for dissatisfaction, and it's hard to get them back on track and to discern what they really want. Sometimes patients obviously just want to be listened to. They want to hear, or they want to sense that you're hearing them. And, whether it's a CPAP clinic or whatever, you may have to let them run for a little bit before they're going to hear anything that you say. So, how do we build this? How do we, in a smaller lab, it's a little bit harder in some ways, and it's a little bit easier in others. In a hospital system or in a more organized recruitment and onboarding system, we can do it through general orientation, through actual training. That, by the way, the Studer training that I'm pulling this excerpt from lasts 2.5 to 3 days. Of course, it's much beyond ADET. It goes into the pillars of excellence in reporting and documentation and accountability and so forth, but there is a real science to it. Just as much as there's a science to what we do, Studer focuses, and his training focuses on science and the art of how to connect with your patients. And doing this, establishing a culture of service excellence, whether leaders are formal or informal, you need to establish those folks. Could be the person's a staff technologist or a staff nurse, but people gravitate toward them. There's natural leaders that are never really deputized or never really promoted that can make a difference in how things are conducted on your unit. However, all staff should be empowered to make decisions within their scope of practice. I'm fond of the story that I tell, and I shared with somebody before we got started this morning, is that my techs in every center that I've managed are empowered to give results of a test. If that doctor is late on the results of that first night's test for 2 or 3 weeks and have not called the patient or not followed up with them, but yet they send them back for a CPAP night. I hated being put in that position, and I don't want my folks to be put in that position because, first of all, it makes it a really challenging sell and night for the patient. But mainly, and more regulatory-wise, is how can they consent to treatment? How can they sign informed consent if they don't know why they're there? And unfortunately, this is one of the most recurring themes, this, and another pet peeve of mine is DMEs substituting mask size and brand after we try to work with them for 9 or 10 hours and, they become non-compliant. They put on what they're on, what they have on the shelf. So empowered decision makers within their scope of practice, can make a big difference. Patient leaves and they think, well, gee, I couldn't get the mask that I thought I was going to get, but I sat down and I saw that my tech, Jane, emailed the DME and said I needed to be on a medium, not a large. Very few folks need to be on a large, obviously, but just whatever you can demonstrate to the patient just goes so far. And this next to the last one here was one of my favorites from years ago. My initial training was with Memorial Hospital in Chattanooga in about 2004. And this contrast and comparison of renters versus owners. And this kind of comes down to like PRN, part-time staff, versus full-time staff. PRN staff may be technically proficient. They may be technically superior, but they're not as invested in the place that you call home, that is your, lab full-time. And the renters can bring down a lab if you have too many of them. And with the COVID and some of the labs that struggled for staffing, there's a lot of travelers, just like nurses. There was a lot of part-time people. And, it's up to you at that point to kind of police yourselves. The natural leader in the group, if not the deputized team leader, might need to pull somebody aside and say, no, you're here temporarily, but we don't do things that way here. And just be real direct. Don't drop hints. Don't, tattle on them. The most effective change for something like that and to keep the team together is peer pressure, in my opinion. Okay, that's not Studer, that's Robert. But anyway, so in building this culture, we also have to have a system of rewards and accountability. And by accountability, I do not mean, and Studer I know does not mean, micromanagement. In fact, just the opposite. The accountability we're talking about is systematic. It's big things like adherence and compliance percentages, total turnaround time from date tested to the date the report's distributed, those kinds of things where you've set annual or periodic goals so that you can provide great customer service. Okay, right people on the bus. This is one of Quint Studer's favorite little buzz phrases, is that, in a labor shortage market that we're in, it's kind of difficult to do this. But if you've got people that don't want to be where they are, it could be that you and your folks, your team, your friends, need to help them realize that they need to return to the community or go back to working wherever they were working before they came to you. Recruiting, not just the right technical skills. Patients, remember I said, assume that we have great technical skills. That's why we're doing what we're doing. But the right fit into the team that's already there. There's nothing more discouraging other than the PRN person that takes over than a new person that comes in. And the new person has, and this is a real world example, has been so hard to recruit that once there, the manager, the coordinator, or the person doing the scheduling gives the new person whatever they want, despite the folks that have been there. I mean, there's just a lot of dynamics there, obviously. But we want to recruit for the right fit, obviously, because not everybody, even if they are in healthcare, is capable of what we're describing here, of being empathetic, of asking the right questions, of controlling their tone, of following up and working on the behalf of the patient. So some people have stumbled into the wrong profession, and we need to help root them out. Okay, owners, not renters, we talked about. Another great example to make somebody feel really cared for, male or female patient. If they're going to leave, especially now that time's about to change again, if they're going to leave in the dark, they wake early, offer to have, if you can, offer to have security walk them out to their car. It's just a great thing to hang your hat on. Staff, checking staff. Peer checking is a really big deal in the hospital. not just for patient satisfaction, but mainly for safety, checking folks. This business of siloed work teams that Studer talks about in 4-bed labs, probably not so prominent or doesn't happen as often, but this business of we and them, when I was at Tuscaloosa, we had a lab on one campus that was managed by a pulmonologist and a lab on another campus that was handled by a neurologist. And when I walked into that in March of 2021, there was the biggest we and them I'd ever seen. And by and large, both the teams were great teams, but they had this thing of, well, that's Northport and that's downtown, and it just rolled on forever and ever. And finally, the two labs merged, and it was my job to help them merge. And once they did, about that time, the lady who y'all have seen me present with a number of times, Paula Williams, had retired from Blue Ridge and called me up and said, hey, you ready to come home? I said, yep, I'll be back. So anyway, staff is everything. Staff can, and this is very appropriate that this is, Sleep Technologist Appreciation Week and Respiratory Therapist and Tech Appreciation Week. Without this, as the fellow last hour said, the doctors get bogged down, the practitioners get bogged down. And we can even get bogged down if we're doing CPAP clinics like this. And by the way, for the gentleman that asked the regulatory question in the back, I've got a different explanation for you. And I do think some of it is about compliance, and it has to do with location of where, because we're billing some of those codes. And all you need is a doctor's order in a different location so that you don't look like you're serving the physician. You're still doing an outpatient education function, just like a diabetes educator. So anyway, we go on. So discharge phone calls. Now, not everyone has the staff to do this, but if you can do it in any form or function, whether it's out of the sleep lab or out of your medical director's office, if somebody will do this, it will provide a higher degree of continuity of care for your patients. They'll understand their next steps better. Their compliance is going to be set up for greater success. And if you can do it within the first 24 hours, especially, that patient's going to feel really cared for. And they'll give you some great feedback then instead of forgetting. They'll say, well, Margie, who took care of me last night, was really great, but she tied that mask down so hard to my face, I'm not sure I can wear it. So you'll get incremental feedback like that you otherwise may not have gotten. Procedure questions and next steps. Anything that you get, though, you need to do something with. Okay, if a patient asks you a question and they count on you to pass that on to the right person if you can't give the answer, then you need to follow that up, because again, this is not just reflecting on your reputation, it's reflecting on everybody's reputation in that lab and that practice. And by and large we make a difference in people's lives. It can make a difference whether or not that patient's compliant. And if they're, severe, their hypoxia takes them down to 75% on 4 liters, then they've got a problem. So, if we treat them like a number, they're going to feel like a number. So, involve the people who are the experts. If you don't know who those experts are, there's somebody in your office or somebody on your team who does. And to make sure that they don't get in this continuous circle of handling and care. A good example of this is patients that used to be, and probably still do take 8 to 10 years to diagnose for narcolepsy. Consider this. Teenager has sleep attacks. They get on this treadmill of going to a psychiatrist, psychologist, then a neurologist. Neurologist finally sends them to a sleep specialist later. And by then it could have been a year or two later, and they get on this track of, I've absolved myself from this, I refer them to so-and-so, and that person that made the referral is covered, but the patient is no closer to where they need to be than they were before they saw that last provider. So if possible, combine that call with next steps and OIC and pull out the file and look at it, or pull it up on Epic or on EMR and say, okay, I see that your DME is, verify a few things at that time. Your DME is AeroCare or your DME is Apria. and that's, oh nope, how about a change in insurance? So a lot of stuff can happen. And as we know, many of these patients have a lot going on. So they've got insurance changes, they've got other family members that are sick, and just a lot of things that we would take for granted are often overlooked or forgotten by the patient. Okay, when all is not well, and I know I'm ahead of myself, but again, there's nothing quite like death by PowerPoint, right? So we're all going to have times where we're on the receiving end of a disgruntled patient or a disgruntled provider. Some of these things, some of these complaints are reasonable, and many times you'll find yourself locked into a situation where none of it's reasonable, but you're the one holding the bag. Issues, elevate issues where appropriate, but if you go back to the A&A debt and just acknowledge and you hear a person out, they're going to give you enough information eventually with enough questions and not diversion, but guidance as you're guiding that conversation like the gentleman last hour described in the 15-minute CPAP clinic. You need to help structure that and guide it so that you understand what the real problem is. If they're just a person that's not going to be satisfied with anything and don't want to be there, well, we all know what that means. You can't do anything with them anyway. But document, document, document. In addition to hearing the patient out, consider protecting yourself, protect the lab, protect the hospital, protect the doctor, and carefully document anything that's stated. Some problems are just an inconvenience fact. And my ER example with prescriptions, my wife is a patient experience manager at a competing hospital in my service area. And people will call up the patient experience line and complain that they didn't get Dilaudid or they didn't get benzodiazepines at the ER or pain meds. And once that complaint is made, whether it's valid or not, it has to be tracked, the letters have to go out, and so forth. So some problems, again, my point, are just inconvenient facts. Fact is, patient wanted drugs, wanted pain meds, opioids probably, but it's turned into a grievance or it's turned into a complaint and has to be handled as such, no matter how silly we may think it is. Okay? And in the sleep lab, the stakes are a little bit lower, but this is an example from an ER that I thought was a good, example of just a fact. The patient was there, they wanted pain meds, but we can't give them to them. And we can't speak or act on behalf of the doctor. We're not licensed to. So, things to consider when framing and managing expectations. This can go a long way in service recovery and handling complaints and handling situations when all is not well. Within your department or your job, you're going to have certain guidelines that you have to adhere by. In many cases, all you'll be able to do is hear the patient out and take notes, copious notes. But carefully manage your tone, okay? You don't want to be accused of anything. But again, in reaction to what a patient may be saying, especially if they're accusatory, a person's first inclination is defense. Become defensive, protect the hospital, protect yourself, or protect the department. All that's fine, but time and place. It's not the right time or place at this point when a patient's just really going off on you. Manage your tone. Again, maybe fall back to some of the ADAT scripting, and whatever you promise or whatever you agree to, it's always been my experience that under-promising and over-delivering, and this is one of Studer's principles too, is if you under-promise and over-deliver, then your patients are always going to think that you've gone a little bit the extra mile for them. And this can be exemplified by the setup of a CPAP, for example. If you know that the DME that they've chosen, AeroCare, Lincare, Apria, sets up people very quickly if they have Blue Cross or if they have Medicare, but they're going to take forever if it's Medicaid, then you can tell the patient, oh, well, you hear somebody within a week or two, and then you know for sure they're going to be called the next day because of that relationship you have with the DME. So you've overpromised, you've underpromised, you've overdelivered, both for you and the DME, and it just kind of strengthens the continuum of care. So Some things, again, are going to be feasible. Some things are not going to be feasible. But if somebody is making a complaint or having a grievance, remember in the paperwork that they've signed with the consents and so forth, if you're a hospital or if you're a Medicare provider, then they've signed something that tells them that you will handle their grievance in a formal way. And you better have a policy on how to handle it. So just saying, anything that you say, anything that you promise, anything that you tell a patient should be documented, and it better be correct. And again, so just use your best judgment. Most of us, I can tell again by the number of folks that I see in here year to year, every year, have crossed this bridge at one point or the other. So how do we frame and manage the expectations of both the doctors and the patients? Again, tone is a recurrent theme, keeps coming up. Some doctors and some patients won't really hear you unless you kind of step it up a little bit. You try a soft approach first. And my wife is perfect at this. I couldn't do her job to save my life. She takes complaints from patients and doctors all day long and makes hospitalists go back and apologize to patients and do all kinds of stuff. I don't know how she does it. But every once in a while, she'll tell me a story about how a patient became verbally abusive and that she absolutely just would cut them off in a way that would probably get me fired or get anybody else fired. But she does it in such a way, it's like, Mrs. Sims, this discussion is over. I'm not going to be talked to that way, and nobody else in this hospital will either. And turns around, walks out. She pulls it off. I don't know how she does it, but I'm just saying, tone is everything. And when framing and defining these expectations, certainly if you've promised anything, make sure it's within your scope of care. And leave no question as to what the next step is. I know I'm repeating myself, but it's worth repeating. Make sure that you're clear with the patient, as clear as you can be. Some patients aren't able to hear exactly what you're telling them, but again, that's why we document. The last thing here is kind of obscured by the lady sitting over here, but avoid speculation. If you don't know the answer to something, don't pretend you do. Just say, Mr. Smith, I'm not sure what the answer is to that, but if you'll give me a few minutes, I'll call somebody who does, or somebody will call you tomorrow, and it'll be either Holly, Dr. Issa, or whoever is going to straighten you out. I don't know, if you need a pre-auth for this or not, or if you're going to need a pre-auth for your next test. So again, we're not experts on everything, but we are experts on our own unit, in our own little domain. Okay, so we're at the finish line with a little extra time for break. Let me recap some main points. Service excellence is a set of behaviors. It's attitude, it's approach. It's not a single event or a program of the day. And this is one of the things that Studer, in his training, when he go from hospital to hospital, making very large sums of money, doing conferences and so forth, but he had the numbers to back it up. He had the patient sat. The Press Ganey scores to show it. It's not just a single event. It's a way of life, a way of doing business, and it's something that's not everyone's suited for. Early in the presentation, I mentioned, not everybody's suited for healthcare. And, if you're not, or if you see somebody coming along just in their 20s or 30s, and you've seen conclusive evidence of this, pull them aside and say, you really need to think about this because it doesn't get any easier. And it really doesn't. You develop better skills to cope with certain things, but healthcare is complicated. And service excellence, of course, is not about always being right. It is a description of an organizational culture, no matter how big or how small that organization is. You can tell right away, usually if you're a patient in a doctor's office or what have you, if the staff there is happy. And if they're not, certainly that carries on to patient care. It is a commitment to doing better and best, to be consistently doing those things, and to have the right people, not just the right skills. Again, everybody in public assumes that we're technically competent, but to have the right people on your team and to represent you when you're not there, because everybody knows where you work, but Jane was seen in the Walmart, playing Karen to the cashier, the checkout, and just making a scene. But, oh yeah, she works over at Advanced Care for sleep disorders or whatever. And so you identify with your team, and you just like you identify with any other social group that you're a member of, whether it's being a Mason, being a member of a church committee, what have you. It all reflects back on your employer. So the right people, and this is why so many hospitals brought in, and even smaller businesses, group interviewing to onboarding people. And if you're not employed by somebody like that, and you just wind up getting somebody, then I hate that for you, but it is getting better. And even with limited staff, we can overcome some of that. Okay, questions on anything that I presented today? If you want to see me after this, I'll clear up some of that because I've been through it 2 or 3 times. Okay, I don't want to trump the guy before me, but I'm just saying I think it's a matter of location when it comes to Stark. So thank you again. Thank you for Zach and the team at Encore Healthcare for hosting us again this year, especially during the week that we're here. And I'll turn it back over to y'all. I'll yield the rest of my time to the break.